Yes, मैम आवाज आ रही है मैम, स्टार्ट कर दीजिए.
Lecture is regarding an approach to the congenital heart diseases. Now, what is the incidence of congenital heart diseases? It is worldwide, the incidence is 0.8%. The risk factors for having a congenital heart disease are a family history of a congenital heart disease, consanguineous marriage, genetic syndromes. General genetic syndromes usually have some congenital heart disease in association, and mostly the Down syndrome. In Down syndrome, 60% patients of Down syndrome have congenital heart diseases. Similarly, Turner syndrome, Edwards syndrome, Noonan's, Williams, all these are associated with some one or the other congenital heart disease. Antenatal factors which cause a risk for congenital heart disease. There are different drugs that are teratogenic, and they can cause congenital heart diseases. Some toxins also they can cause. So therefore, drugs in pregnancy, for example, antipsychotic drugs, anti-failure drugs, many of them, they are not recommended to be taken in pregnancy because they have teratogenic effects and they cause congenital heart diseases. Infections mostly include rubella, toxoplasmosis, cytomegalovirus, and herpes. All of these, they cause congenital heart disease is in the child if the mother has these diseases during the pregnancy. And maternal diabetes, whether it is gestational diabetes or type 2 in the mother, both are associated with the risk of heart disease if it is not controlled properly. Recurrence with the family. Now, the recurrence risk in the family with the congenital heart disease, if the mother has a congenital heart disease, then there is a risk of 2 to 20% that in the child. The risk with the father, if the father is having any congenital heart disease, the risk in the children is 1 to 5%. It is a little bit lesser when the father has a disease, but when the mother has a disease, there's more. If the sibling has the disease, then the risk of congenital heart disease is 1 to 6%, but it increases with each sibling. For example, one sibling has the risk disease, it is 1 to 6%, but if there are two elder siblings that are having congenital heart disease, the risk increases, and so, it sometimes increases up to 10% for subsequent pregnancy. Again, if a parent and a sibling both are having congenital heart disease, then the risk is again more. Okay, now the screening for the congenital heart disease. What screening should we do to see whether the child can have a congenital heart disease or not? Now, these are the tests, the blood tests. If a mother is suspected to have some infection, then you have to go do this test. This is known as a torch profile. This is a blood test in which you test for T stands for toxoplasmosis, R is for rubella, C is for cytomegalovirus, and H is for herpes. So this is a profile of these viruses which is tested in the mother to check whether the mother is having this infection because they cause congenital heart disease. Secondly, we do during the pregnancy, other than the fetal well-being, we also do this anomaly scan, ultrasound for fetal well-being associated with this anomaly scan. In this anomaly scan, we check whether the child is having a congenital heart disease or not, or any other disease. The anomaly scan is for all the systems actually, but we are talking presently of the congenital heart disease, so we talk about that. If there is something abnormal found in the anomaly scan, then what we do is the fetal echo. Fetal echo is done for the high risk. In the fetal echo, we come to know whether the child is having a particular congenital heart disease not. And according to this fetal echo, we can counsel the parents regarding regarding the plan for delivery, plan where the delivery should be made, how the delivery should be made, and to minimize the risks to the mother and the child. Now, after the child is born, what we have to do is a newborn examination. Complete head-to-toe examination of the newborn will let us know whether the child is having a congenital heart disease or not. Head-to-toe examination में आपने सबसे पहले देखना है that the child is looking normal or not, whether the child is syndromic. तो आपको उसका general appearance देखना है, उसकी facies देखनी है, head है, eyes, nose, the tone of the body. All this is important to see for the syndrome, to check for the syndrome. If the child is having any such thing, or if the child is not having a syndrome, then again the important thing to rule out the congenital heart disease is saturation. Saturation should be checked. So most of the time with the congenital heart disease, the saturations are dropped, especially in the cyanotic heart disease. In the acyanotic heart disease, the saturation is above, that is normal, that is above 95%, but in the normal, in the cyanotic heart disease, saturation goes below. Auscultation to find a murmur. At the time of birth, usually the murmurs are not present. Usually most of the murmurs, they come after the third week of life. So at the time of birth, the auscultation, you can, on auscultation you can get the murmur, but it is not always present. Now, here you can see this picture. In this picture, you can see what a fetal heart looks like. Now, you know, in the fetus, all the blood is oxygenated in the placenta. The lungs are actually hypoplastic. They are not aerated during the fetal life. They are in the collapsed form, and all the blood gets oxygenated in the placenta. From the placenta, the oxygenated blood goes through the
मैम आवाज कम आ रही है आपकी.
it bypasses the liver through this duct that is known as the ductus venosus. It bypasses this duct through the ductus venosus, and it oxygenated blood enters into the right atrium. It enters into the right atrium. Now, most of the blood from the right atrium enters directly through the PFO. The PFO is a patent foramen ovale. That is a defect that is present in the fetal heart that connects both the atria. This is both the atria are connected in the fetal life through a defect that is known as a PFO, or a patent foramen ovale. And all the most of the oxygenated blood which comes into the right atrium goes directly from the right atrium into the left atrium. From the left atrium, what happens? The blood goes into the left ventricle. From the left ventricle, the blood goes into the aorta. Okay, the oxygenated blood which came from the placenta through the umbilical vein, bypassing the liver through ductus venosus, entered into the RA. Most of it entered into the LA through the patent foramen ovale. From the LA, it went into the LV. From the LV, it went into the aorta. From the aorta, here you can see the aorta. In the fetal life, the aorta is connected to the pulmonary artery through a duct that is known as a PDA, or patent ductus arteriosus. This duct connects the aorta to the pulmonary artery. So this PDA, what happens when the blood goes from the aorta to the pulmonary artery? Some of the blood goes through from the aorta to the pulmonary artery through this PDA, and enters into the through the pulmonary arteries into the lungs. So this blood goes to this oxygenated blood goes into the lungs and causes the lungs to causes the lung tissue to get the oxygen. rest of the blood goes into the descending aorta. Rest of the blood goes into the descending aorta and into the whole body. From the whole body, when the whole body gets oxygenated, the deoxygenated blood is the deoxygenated blood is collected by the umbilical artery, and it is brought back into the it is brought back from the heart into the it goes through the umbilical artery back into the placenta. So you see, this is the fetal circulation. This is here you can see the four chambers and how this blood goes into these chambers. Now, what happens when some of the blood from the right atria enters into the right ventricle? It goes into the PA, and this PA, some blood goes to the lungs, and the rest of the blood through the PDA comes into the descending. And now all this blood gives oxygen to the body of the fetus, and then the deoxygenated blood goes again back through these umbilical arteries back into the placenta. Now, any defect within the heart will lead to the congenital when these things persist. For example, this foramen ovale, if it persists after birth, it causes a problem, then it causes a congenital disease. If this PDA or patent ductus arteriosus, it remains in the heart after the birth, then again it causes problem. Okay. Now here we can see we said we have to do the oxygen saturation. Now where the oxygen saturation should be taken? The oxygen saturation is taken from the right hand, and from one other limb, that is a left hand or a right foot or a left foot. Because when after birth, if there is a persistent PDA, I told you that PDA is a connection between the aorta and the pulmonary artery. So what happens that this through this PDA the blood is mixing. So if the child has a saturation difference in the upper and the lower limb, then also it suggests a congenital heart disease, and a congenital heart disease along with a PDA. There can be a PDA alone. In the PDA alone, what happens? The saturation of this hand, that is right hand, would be less, and the left hand would be more, because oxygenated blood is coming through the aorta into the PDA, which is causing this the decrease of the saturation in the lower limbs. And if it is associated with some congenital heart disease, what happens? That the saturation in the right hand is decreased, whereas the saturation in the lower limbs is better. Now, what are the groups of the congenital heart disease that are present? The groups of congenital heart disease that are present are acyanotic. The other group is the cyanotic heart disease, and the other group is obstructive heart disease. Okay. Acyanotic heart disease means there is no cyanosis. Congenital heart disease is present, but there is no cyanosis, means there is a left to right shunt. That is, the blood is shunting from the left side of the heart to the right side of the heart. In the cyanotic heart disease, because the blood is shunting from the right side of the heart to the left, therefore it is called a cyanotic heart disease. Obstructive heart disease, there is some obstruction to the flow, that is to the pulmonary flow or to the systemic flow. So there is some obstruction in the systemic flow, or that is systemic flow, that is the flow to the body. So flow to the body, as we have seen in the previous picture, the flow to the body goes through the aorta. So if there is any obstruction in the left side, for example mitral valve, aortic valve, or the aorta itself, then it is an obstruction in the systemic blood flow. And obstruction to the pulmonary blood flow, if the blood is not going into the lung obstructive lesions, and some of the lesions of the cyanotic heart disease, they are duct dependent. Duct dependent means PDA dependent. PDA, the patent ductus arteriosus, which is a normal structure that regresses after birth, has to be if some lesions are dependent for circulation on the PDA afterwards. And if the PDA closes, they cannot survive. Therefore, we say these are duct dependent lesions, and in that case, we try to keep the duct open by medications. Now, details of acyanotic congenital heart diseases. Acyanotic conditions in the acyanotic conditions, I told you there is a left to right shunt. They are more common type of congenital heart diseases, and the most common of the acyanotic disease is a VSD. VSD, 15 to 20% of the cases are with VSD. The other one is the ASD. ASD occurs in 5 to 10% cases. Then the PDA, it also occurs in 5 to 10% of cases. And then the AV canal defects. AV canal defects include that they have an ASD as well as the VSD. Both are present, but they are sort of less common than the VSD and ASD alone. And then the other is the coarctation of aorta. Although coarctation of aorta is an obstructive type of disease, but we also include it in the acyanotic, but because many types of coarctation of aorta do not cause cyanosis. Acyanotic heart disease is, what is the presentation of the acyanotic heart disease? The acyanotic heart disease, they present with recurrent chest infections. They are usually failure to thrive. They can present with congestive cardiac failure. The CCF means congestive cardiac failure. They have difficulty in feeding. The mother complains that the child is unable to feed properly, and therefore they do not gain weight, and they become able to thrive. They have dyspnea, that is difficulty in breathing. Difficulty in breathing due to increased blood flow to the pulmonary to the lungs. Increase because of the left to right shunting, there is an increased blood flow to the lungs, which causes pulmonary edema, pulmonary congestion. Therefore, the lungs are wet and the child cannot breathe properly. They are also associated with orthopnea. Orthopnea means orthopnea means that the child is having respiratory difficulty while lying down. When the child lies down supine on the bed, the child has difficulty in breathing, and it is also because the lungs are congested, and when the child lies down, because of the gravity, the whole of the lung gets congested, and therefore the child has problem in breathing the lying down position more, and the child feels better when he sits up. And then you can, the child patients also present with an incidental murmur, because there is a small defect, for example, a small ASD or small VSD or small PTA. Usually the children do not have these complaints. It is they come to notice with an incidental murmur. When they go to a pediatrician during examination, the pediatrician finds a murmur, and then the child is referred for to a congenital heart disease specialist. Now, the acyanotic diseases, the clinical findings and the symptoms both depend on how much is the severity of the acyanotic condition. That is, how large is the defect. These are usually shunts, which are left to right shunts, and the smaller the shunt, the lesser are the symptoms. The larger the shunt, the more are the symptoms. So when the shunt is small, the child is totally asymptomatic. When it is of a moderate size, the child has some symptoms, and usually the symptoms are not present in the infantile age, but when it occurs when in adolescent, when child starts growing, playing, running, then the child comes to notice. But in case of very large defect, the child come into notice in the infantile period, and sometimes even in the neonatal period also. Now the children presents the clinical findings at the time of presentation. In children with large defect, they can present with the congestive cardiac failure within the first year of life. That is, within congestive cardiac failure if the child is having a very large defect. These congestive cardiac failure can be present within the first year of life, but if it is a very small defect, usually the child goes asymptomatically up till adulthood also. If it is a moderate defect, then these findings, congestive heart failure findings, come during the adolescent period. On the precordium examination, you will find a hyperdynamic precordium, an abnormal heart sound, that is, their beats are not as they should be normally. There is some difference, and then you can have an added sound. Added sound means a cardiac murmur. The cardiac murmur at the place of the congenital heart lesion, where the lesion is. For example, the murmurs of VSD are present at the lower sternal border. The murmurs of PD are present in the right upper sternal border. In the left upper sternal border, where the murmurs of the AST, they are also present in the upper portion, on the upper sternal area on the left side. And then if there are the findings of CCF are present, the child can present with crepitations in the lungs. Acyanotic diseases, what, how will you manage the acyanotic disease? The basic approach for management is definitely, if the child comes to you and the child is sick, you have the basic management approach as in any other disease, that is an ABC approach. Because what happens that always there are some supportive management and some other specific management. So specific management would be the management of the disease, but supportive management would be the management of the symptoms at the time of presentation. If the child presents to you in the asymptomatic phase, definitely you will just counsel the parents regarding the disease, and you will advise them for a corrective surgery. But no, you will not restrict them for any sports. You will not restrict them for any dietary advice, and you will not also start any medication. But if the child has a moderate sort of a lesion and child is having few symptoms, for example, a dyspnea, orthopnea, or exercise intolerance, or the child you see is a failure to thrive child, then you will start medication. But if the child comes to you and is very sick at the time of presentation, you will start with the ABC approach, that is, maintain the airway, correct the breathing and correct the circulation. यानी आप उसको ऑक्सीजन लगाएंगे, उसको प्रॉप अप करेंगे, ठीक है. उसके बाद यू विल एस्टैब्लिश द ब्रीदिंग. अगर उसको प्रॉपरली ब्रीदिंग हो रही है, ठीक है. अगर नहीं है तो यू विल स्टार्ट द ऑक्सीजन. अगर ऑक्सीजन से भी नहीं हो रही, विल अटैच अ CPAP. और if the child is very sick, you have to intubate the child and put on ventilator. And if the child is if the child is having any problem in the circulation, that is, the pulses are low, pulses are weak, poor perfusion, the child is having mottling, or the child is having low blood pressure, definitely you will maintain an IV line, and you will start IV fluids. You will give a bolus to the child, and then you will start IV medication. So you have to, if the child is very sick, comes to you, then acute management is airway, breathing, circulation. You have to maintain first, and then you will move forward to the specific management. Specific management will include anti-failure medications. Anti-failure medications you will start in the form of intravenous in the emergency, but later on you will continue as oral medication, oral anti-failure medication. Then you have to counsel the parents and the child regarding preventing infections, because in this children, the congenital heart disease, the children can develop infective endocarditis. So you have to give them antibiotic prophylaxis for infective endocarditis, for preventing infective endocarditis. Treating the infections promptly. If there is any sign of infection of any system, that has to be treated. Otherwise, the congenital heart disease patients are more prone to develop an infective endocarditis if the infections are not treated promptly. Monitor the growth. The growth should be monitored, the height, the weight, the BMI, because these patients with a congenital heart disease, as I told you, if there is a large defect, the child is not able to feed properly. Secondly, it is a hypercatabolic state. The energy of the child is lost with that hypercatabolic state. Therefore, they need to be given a high caloric diet. And if they are not on a high caloric diet, then they will not gain weight. And usually, children with moderate to severe acyanotic congenital heart disease, they come with a growth failure. So every time you have to monitor the growth, you have to counsel the parents regarding the dietary support. You have to give a high caloric diet. You have to give supplements along with the diet if the child is not gaining weight, and you have to maintain a good dental hygiene, because dental hygiene is associated with infective endocarditis. If dental hygiene is not maintained, the children can develop infective endocarditis, and definitely the definitive treatment would be a surgery. If there is a ASD, closure of ASD, if there is a VSD, closure of VSD, if there is a PDA, closure of PDA. Now, nowadays, a lot of diseases are not corrected by a open heart surgery, but they are done usually by the cardiac catheterization. We can close these defects in the cardiac cath lab by devices. So that open heart surgery is has not to be taken into account, but their specific intervention has to be done, whether, and we will have to assess the child whether it can be closed by a device or not closed by a device. Then we have to proceed for an open heart surgery. Cyanotic congenital heart disease. Now, the other group of the congenital heart disease is cyanotic heart congenital heart disease. Cyanotic heart disease means that the child is having some shunt in the heart, that is from right to left. Right side contains the deoxygenated blood, so right to left shunting will result in cyanosis. So we call it a cyanotic heart disease. The cyanotic heart diseases are divided into two broad categories. The cyanotic heart disease with decreased pulmonary blood flow and with increased pulmonary blood flow. If in the cyanotic heart disease, they are associated with an obstruction to the flow towards the lungs, then it comes with decreased pulmonary blood flow. For example, teratology of Fallot. Teratology of Fallot, what happens in this? It is associated with a large PSD. As the word says, teratology. Teratology means 4 defects are present in this type of the heart. It is associated with large VSD, hypertrophied RV, RVOT obstruction, that is right ventricular outflow tract obstruction. For right ventricular outflow tract obstruction means obstruction in the infundibular part of the right ventricle and also in the pulmonary valve. So these cause decrease in the pulmonary blood flow. Okay? The other, with the decreased pulmonary blood flow, it is a transposition of great arteries with a VSD and a PS. Transposition of great arteries mean that the connection is not properly done. The connection means that the RV is connected to the aorta. RV, normally the RV, that is the right, normal connections are that the right atrium is connected to the right ventricle and right ventricle goes to the pulmonary artery, as I showed you before in the picture. But in the transposition, what happens that the right atrium is connected to the right ventricle and right ventricle opens into aorta, and the left ventricle, it opens into the pulmonary artery. So there's a transposition of the great vessels. The pulmonary artery, which has to be attached with the RV, it is attached with the LV, and the aorta, which has to be attached with the LV, is RV. And transposition of great arteries, if it is associated with the VSD and a PS, then if it is a pulmonary stenosis, if there is a pulmonary stenosis, the lung flow is decreased. sorry, we'll start again. The transposition of great arteries with the VSD and PS. This is associated with the decreased pulmonary blood flow. Then pulmonary atresia. If the pulmonary artery is not, if the pulmonary artery is is atretic, that is, it means it is closed. It is not canalized. It is again a congenital heart defect that during the embryological period there is some problem in due to which the pulmonary artery become atretic, so there is a decreased pulmonary blood flow. Same as if there is tricuspid atresia, that is a tricuspid valve is atretic, there is no forward flow towards the RV and then no forward flow to the lungs also. With the increased blood flow, the transposition of great arteries with a VSD and or ASD, but no PS, that is no pulmonary stenosis, so blood would go to the pulmonary arteries. And transposition has to be associated with some intracardiac shunt, that is a VSD or a ASD, because the survival is not possible in the transposition without any shunt, intracardiac shunt, because you know that the connections are opposite, that is RV is connected to the aorta. So what happens, the deoxygenated blood goes into the aorta and to the whole body, so the body gets the deoxygenated blood, and the oxygenated blood goes again and again into the through the pulmonary artery, through the LV into the PA and again into the lungs. So if there is no connection between the oxygenated and deoxygenated blood, the survival is not possible. So naturally there is a connection between the pulmonary artery and where there is a connection within the heart to mix the blood oxygenated and the deoxygenated, so that the survival is made possible. Now this connection can be at the level of the atria, so it is called the ASD. If the connection is at the level of the ventricle, it is called the VSD. If the connection is at the level of the great arteries, it is called a PDA. But if this connection is not present, we have to make an artificial connection. And then when we talked about previously of duct dependent lesion, this is one of the duct dependent lesion. If there is no there is no connection between the oxygenated and deoxygenated blood, you have to keep the duct open so that the oxygenated and deoxygenated blood can mix. Okay? Truncus arteriosus again, it is a condition of cyanotic heart disease with increased pulmonary blood flow, and also it has a poor prognosis. Total anomalous pulmonary venous return, it again is associated with the increased blood flow. Okay. Now the cyanotic heart disease, they present with the presentation of the cyanotic heart disease depends upon the severity of the stenosis. The severity, the more severe the stenosis, the more will be the cyanosis. Definitely, so the child will be more sick, and there it also depends on the presence of an intracardiac shunt. If the intracardiac shunt, as I have told you, that it is present at the level of atria or ventricle or great arteries, that is the ASD, VSD or PDA, the presentation would be late. The child would not be much sick, but if these shunts are not present or very small in size, then the child will present early and the child would be sick. So these they present in infancy, if not at birth. If their child is very sick, the shunts are very small or absent, then it will present at birth. If they are larger, then it will present in infancy. If they present just after birth, it means the child will be very sick. The child usually has a disease such as called hypoplastic left heart syndrome, the pulmonary atresia or critical pulmonary stenosis. This will present just after birth, and the child will be very sick, very much cyanosed. And clinical findings also depend on the amount of the pulmonary blood flow, how much the flow is going to the lungs. That is also dependent upon the presentation of the child. Cyanotic heart disease present with central cyanosis. Why does central cyanosis occur? Central cyanosis occurs because of the desaturated blood present in the aorta. The desaturation of the arterial blood causes central cyanosis. By central cyanosis, we mean the cyanosis of the oral cavity, the oral mucosa, that is the tongue. Okay, so this is the if only the lips or the peripheries, that is the tips of the hands and the feet are cyanosed, this is not central cyanosis, it is peripheral cyanosis. We have to see the oral mucosa. If the oral mucosa is cyanosed, then it is the central cyanosis. If oral mucosa is cyanosed, it is not never normal. Peripheral cyanosis can be present with other conditions, and it is usually normal also just due to exposure. The children get peripheral cyanosis. Uh, if it is associated with increased blood flow, they can present with failure. Or if there is increased back pressure in the lungs because due to some obstructive disease, then also the children can present with failure. The children will present with abnormal heart sounds and murmurs. The children can present with clubbing. Clubbing occurs in takes time to develop. That is, when the children would present, they will present with clubbing would now, cyanotic heart disease की मैनेजमेंट आपने कैसे करनी है? आपने उनको ऑक्सीजन देनी है. इफ दे आर सिक, दे रिक्वायर ऑक्सीजन, आपने उनको प्रॉप अप करना है. उनको भी बिल्कुल इसी तरह एबीसी में पेशेंट को प्रॉप अप करेंगे, उसको ऑक्सीजन देंगे. ऑक्सीजन सिर्फ नेजल प्रोंग से. इफ द चाइल्ड इज नॉट इम्प्रूविंग, यू हैव टू स्टार्ट अ बायपैप. यू कैन आल्सो intubate the child and start on ventilation. अगर duct open रखिए, if there is a duct dependent lesion and you think the child is not improving, then you have to start intravenous prostaglandin infusion in the form of prostaglandin E2. Sorry, this is E2, not E1. You have to give hydration because most of these children are acidotic. You have to give hydrate these children properly. You have to correct the acidosis by giving sodium bicarbonate. You have to correct the electrolytes. You have to maintain the RBS. And then, as I told you before, the specific management. The specific management would be the corrective surgery of the underlying lesion. Sometimes before the corrective surgery, you have also have to undergo a palliative surgery. The palliative surgery is for survival. Sometimes the children are very sick. They cannot survive with this management only. They need a palliative surgery, which is a bridging surgery towards a corrective surgery. For example, due to the low age of the patient, the child is a very small heart, the arteries are very small, the veins are very small, so a corrective surgery cannot be performed. So, to buy the time that the child grows up and the structures of the heart grow up, and so that a corrective surgery can be made possible, we have to give a palliative surgery. The palliative surgery can be a shunt, it can be a PA banding, it can be in any form. In case, for example, when I told you a transposition of great arteries is associated with an intact septum, that there is no shunt, in that case we do an atrial septectomy, that is, we make an artificial septum by breaching the atrial septum. Now come the obstructive congenital heart disease. The obstructive congenital heart disease include systemic obstruction, that is obstruction in the left outflow tract, or the pulmonary obstruction in the pulmonary circulation, that is the right outflow tract. I had already discussed before that systemic circulation includes the left side of the heart, that is the left atrium, the left ventricle, and the aorta. So any obstruction in that area, any obstruction in the mitral valve, any obstruction in the aortic valve or the aorta itself will cause us left outflow tract obstruction, that is, will be a mitral stenosis, an aortic stenosis, or a coarctation of aorta. Okay? And pulmonary circulation is dependent on the right side of the heart, that is the right atrium, atrium, right ventricle, and the pulmonary artery. So any defect in the tricuspid valve, the pulmonary valve, will cause a right outflow obstruction, and it is can be due to tricuspid atresia, tricuspid stenosis, pulmonary atresia, or pulmonary stenosis. So the flow to the lungs is affected. ठीक है. अब obstructive heart disease, how would the obstructive heart disease present? Presentation of the obstructive heart disease depend upon the degree of obstruction and the associated defects. Now, how much is the degree of obstruction? If it is a mild obstruction, definitely the child would be asymptomatic. If it is a moderate degree of obstruction, child will have symptoms, start having symptoms in the adolescent period. But if it is a severe obstruction or a total obstruction, for example in atresia, the child will present in a very early age, that is only in the neonatal time. So it is the degree of obstruction, it depends on the presentation and the associated defects. For example, if there is an obstruction alone, or if it is associated with when the defects, for example, it is a pulmonary stenosis associated with a VSD, या DTG with PS associated with an ASD, VSD, ठीक है. So the depend upon the associated lesions of the heart, and usually the lesions of the heart are associated complex heart diseases. So if the degree of obstruction is severe, the child will be associated with breathlessness. Breathlessness can come in the neonatal period if degree is severe. If it will come later on adolescent period on exertion with a moderate to severe obstruction, mild to moderate obstruction. The child's severe obstruction can result in shock and cyanosis. For example, I told you a HLH patient, hypoplastic left heart syndrome, in which the whole of the left heart is small and the systemic blood flow is not maintained. Therefore, the child goes into shock. The obstructive lesion can also present with congestive cardiac failure. Congestive cardiac failure, why? Because as there is no forward flow, what happens? The blood pulls backward. There is a backward pressure, but blood pulls backward. And what is on the back? The lungs. The blood is not flowing through the heart. It is not going to the system. So what happens? The blood starts pulling into the heart. In the lungs. So the child will develop a congestive cardiac failure. And cyanosis, definitely if it's a pulmonary atresia or a tricuspid atresia or a severe HLH, can present with a cyanosis. In the obstructive conditions, the clinical findings are they can present with a murmur. There will be difference between a pre and post ductal saturation. I told you before, because of the PDA, what happens in case of obstructive lesions, the saturation is less in the upper arm and it is more in the lower limb, because the PDA is giving the blood. And if there is a cyanotic heart disease, then it is different. The upper arm saturation would be less, and in the lower body the saturation would be more. So if there is a pre and post ductal saturation difference, you have there should be an alarm in your brain that there is some congenital heart disease present. Reduced or absent femoral pulses. In case of coarctation of aorta, the pulses in the upper limb are normal, but pulses in the lower limb are weak, very weak. Usually you cannot find the pulses and you say there are absent pulses. So if the child is alive, the pulses could not be absent. Definitely they could be very weak, as said, that you cannot feel them. Or a child can present with cyanosis or shock, as we have already discussed. Now, what will be the management of the obstructive lesions? Again, you have to, if the child is sick, if the child is cyanosed, if the child is breathless, you have to maintain the airway, breathing and circulation. You have to prop up the child. You have to clear the airway. You have to give oxygen. You have to give through the nasal prongs, if not maintaining through the CPAP, or you have to intubate the child to give start the ventilatory support depending upon the condition of child. You have to maintain the circulation by maintaining an IV line. IV cannula is passed, IV fluids are started. You have to hydrate the child. If the child is very sick, you can also start the inotropic support. Again, if in case of severe obstruction, the blood flow is maintained through a PDA. Now, these obstructive lesions, if they are very severe and they present in the neonatal age, we call them, they are duct dependent, and the survival is not possible if the PDA gets closed. So you have to keep the PDA open. The PDA is kept open by this medicine that is known as injection prostaglandin E2. You have to start the infusion of prostaglandin E2 until the duct gets opened, or the child is prepared for a emergency surgery or emergency shunt. Okay, duct dependent lesions, which are the duct dependent lesions? Here you can see, this is a picture showing the arch of aorta. It is coming out of the LV, and this is the pulmonary artery that is coming from the, sorry, this is the duct. This is a PDA that is coming from the arch of aorta. It is connected from the arch of aorta to the pulmonary artery through this PDA. See, so this is the patent ductus arteriosus, and the obstructive lesion, the duct dependent lesions, which in which the PDA has to be kept patent, is tetralogy of Fallot with pulmonary atresia. Again, a cyanotic heart disease and pulmonary atresia, no blood flow to the lung, so these are duct dependent. Again, critical pulmonary stenosis, that is, stenosis is so severe that the blood flow towards the lungs is not going. And transposition of the great arteries with the intact septum, that is, transposition of the great arteries with the intact septum, that is, if I told you, transposition of great arteries, patient cannot survive if there is no intracardiac shunt present. If there is no mixing of the oxygenated and the deoxygenated blood, the survival is not possible. So if there is an intact septum, what you have to do, you have to start a prostaglandin E2 infusion to keep the duct patent. The PDA should not close, and by that time you can prepare the child for an emergency procedure that is known as atrial septostomy. That is, you will in the cath lab, what you will do is you will make a ASD. You will, if there is a PFO and a small size PFO, you will increase the size of PFO. If it is totally absent or closed, you have to make a new one. So you have to give a prostaglandin E2, and then you will give atrial septum. You will make an iatrogenic atrial septal defect by an atrial septostomy or an atrial septectomy. Okay, duct dependent lesions. What are the other duct dependent lesions in which the systemic circulation is obstructed are the hypoplastic left heart syndrome, a critical aortic stenosis, severe coarctation of aorta. These are and transposition of great arteries with intact septum. Again, these are I have written the transposition both for primary circulation and for systemic, because it is required for both the circulation, because mixing is required. When the blood will be mixed, then only the systemic and the primary circulations can be maintained. Keeping the duct open, we have to give prostaglandin E1, and this is a dose of prostaglandin E1. We have to monitor for the side effects while giving any medication, as we have to monitor with the prostaglandin E1, because prostaglandin E1 is associated with apnea, arrhythmias, diarrhea, fever, seizures, vasodilation. Now, with this, we come to the end of our topic. Hope you enjoyed the lecture and it was useful for you. We cannot have any question answer session, I think. So when you people come to the boards, you can ask any questions if you have any queries. I'm Dr. Amber Kamran in the PEDS Unit 2, so you can come over there if you have any query regarding the congenital heart disease, and you can ask questions. We can have a repetition in the ward classes of this also.
मेरे